Next is Mr. Sham Kashyap, who will talk about Arogyashreni. Mr. Kashyap has a multidisciplinary academic background, master's degree in computer science and agricultural economics, and worked in the development sector in various capacities, including that of social scientist, policy analyst, subject matter expert, etc. His research interests include agricultural policy analysis, computer-aided policy simulation models, and decentralized rural governance systems. At the organization he is working now, he currently coordinates projects related to health governance system. Sham.
Hello everybody, I'm Sham Kashyap and I represent an organization called Grassroots Research and Advocacy Movement. This organization was started by a service-based NGO called Swami Vivekananda Youth Movement, which has about 30 years of experience in the Mysore district. We work on issues ranging from education, sanitation, health, and rural development. So what I'm presenting today, this project called Arogyashreni, is an experiment which is born out of this 30 years of grassroots experience. So Arogyashreni is necessarily an action research project which actually takes a lot of issues that have already been discussed so far in this conference. To quote a few people, yesterday Siddharth Agarwal talked about the power of the community and how much access and the quality of access that gets if the community seems to have good power. Juliet today morning, she talked about community-based evidence generation, and the whole session today here in the Seasons Hall talked a lot about the decentralization and how, what is the context in which decentralization is working or not working in the context of NRHM. So based on these experiences and also the grassroots experience on these issues, this project was devised. So the agenda for my talk is basically a review, a very small brief review of what are the community monitoring mechanisms that exist in NRHM, our own grassroots experiences, and what our project is all about, some initial results, and what can be learned and what can be taken forward. So community community participation, especially through NRHM, has been supported widely in NRHM, and you can see there are quite a few committees that have been established as part of NRHM. So we have village health, sanitation, and now nutrition committees, sub-center committees, Arogya Raksha Samitis in Karnataka, or the Rogi Kalyan Samiti elsewhere, the planning and monitoring committee. So there are a lot of these committees, and community representatives are involved in all of these committees. Some of the issues that that strike us are that so some of the issues that strike to us are although people come from the same background, the representatives in each of these committees are supposed to do very different types of jobs. So the competencies are, expected competencies are very different, but community representatives come from the same pool of from the same pool in the local community. We also see that in the implementation of NRHM, the difference in priorities given to capacity building to each of these committees is very wide. So for example, VHSNCs and ARSs were given the first priority, whereas planning and monitoring committees of the PHCs are almost non-existent. Sub-center committees are, usually they're just for namesake. So there is wide difference in terms of how these committees have built their capacities. Further, as discussed in the last session, there is a lot of field level uncertainties in roles and responsibilities of what each of these committees are supposed to do. So this forms some sort of a vertical setup. There are also horizontal uncertainties between the role of Panchayat Raj institutions and these committees. Are they subsumed within the Panchayat Raj institutions? Are they really separate entities like school development and monitoring committees, SDMCs? So I'm not really talking about the guidelines and the way this was supposed to be structured at the policy level. These are the grassroots level issues that I'm trying to pick up. And in this project and for my presentation, I'm only sticking to committees, and also my discussion is basically focused at the PHC, primary health center level. So community monitoring in NRHM as it is envisioned is part of a three-pronged approach to create accountability. So community monitoring is supposed to help both the public health system as well as the community. For the public health system, the system gets to understand and be responsive to local community needs. It also tries to see whether status of fulfillment, what is the status of fulfillment, and it's also a way of validating internal monitoring. But what it actually is supposed to give to the community is that the community, through community monitoring, can, this is supposed to lead to community action, which could be changes in, change in awareness levels, change in attitudes towards health, and also participation, true participation in the governance of public health committees, public health centers. And as a byproduct of that, community to actually own primary health centers and its services and delivery mechanisms. But that is what, was envisioned, but what do our grassroots experience tell us? It tells us that community participation is almost non-existent in key decisions. In many cases, community participation always is also, it leads to non-cooperation. It could be corruption issues, it could be issues with respect to issues like lack of information and control. A lot of this was discussed, so I'm just going to cruise over them. So information and control, lack of that creates power gaps, and power gaps means that community monitoring itself doesn't seem to actually cater to community needs. One other striking feature is that what NRHM is supposed to entitle communities and what actually exists in PHCs, the difference is so wide that the community doesn't really feel that it can do anything with community monitoring. So for example, a 24/7 PHC is supposed to have 3 doctors, there is not even 1 doctor in place. So what is the community supposed to monitor? So these are some of the issues at the grassroots. There is also wide difference between what the guidelines say and what what is actually practiced. And also in the perception of the community, what is the exact expected improvement they want in their PHCs and what are feasible. So for example, some communities, when we go to them, they say that we want a super specialty hospital in this PHC, which is simply not possible. So there are different levels of expectations as well, all of which contribute to making sure that community monitoring, if at all it exists, becomes just ritualistic. So in this context, we set out to conduct this action research experiment called Arogyashreni. Arogyashreni, if you just split that term, it means Arogya, which is health, and Shreni, which is grading, which is, grading public health, public service institutions is not something new. But what we are trying to assess here, and our main research question here is that can community monitoring then, with this current existing context, be used as a tool for actually seeing the performance of public health centers? So this being an action research project, it also has a few things that the community itself wants to do and things that we need to change, which is to develop a sense of ownership, to build or bridge the information gap that exists between health personnel and community representatives, and enhance, and through this we are that the community's demand for health services will be enhanced. And as a part of achieving all this, we set out to build a low-cost technology-based platform which can analyze the community monitoring information and help in disseminating it. So the methodology that I'm presenting here, none of the individual components here are new. Capacity building has been done, community monitoring has been tried out in various stages, and based on that, community-based ranking cards are also, have been developed elsewhere. What we claim to be kind of an innovation here is that we are targeting community representatives who are supposed to do community monitoring and who are supposed to be involved in planning and monitoring of the PHC. So we are not really targeting users here. It is supposed to be, if you take the examples of panchayats, Panchayat Raj elected Gram Panchayat members trying to monitor their own panchayats. So the capacity building activity that we did here was we selected one community person, a resource person who was already trained in this field, and we took 3 VHSCs in that particular PHC, Village Health and Sanitation Committees, and those 3 VHSCs were represented by their own one member and one ARS or Arogya Raksha Samiti member who is generally the Gram Panchayat president of that particular panchayat. So there were 5 such people monitoring each primary health center, and these 5 members were asked to monitor their PHCs using a a community monitoring questionnaire which was given to them monthly. The responses that these members gave were recorded through an IVRS or a toll-free number on which the responses can be registered automatically. And for this, the questionnaire was basically a yes or no type close-ended questionnaire. So once the questions were answered, we tried to score the PHCs based on this and rank them. This was followed by field validation, and the ranking dissemination happened. So the next step is the crucial step where we started going back to the community representatives and analyzing their own answers and trying to see what kind of change they can bring, rather than demanding for some of those changes. So this advocacy part of the project is still under discussion, so is still under implementation, so I'll be focusing on the first three aspects of this. So to go into the project details, we conducted this experiment in Mysore district with 112 PHCs out of 119 rural PHCs. The monitoring took place monthly. There were 12 categories of yes, no type close-ended questions. There were 79 questions. It seems to be a lot, but the rationale was for these VHSCs to build their own awareness, build their own information base for their PHCs, as well as contribute to the monitoring mechanism. So mostly the questions were taken from IPHS and contextualized in the local context. The questionnaire was devised based on stakeholder consultations, doctors, public health personnel, field activists, community representatives themselves, all of them were involved, which was followed by capacity building in terms of concepts of community monitoring and community action. And here you can see the stakeholder workshop as well as the training mechanisms, and a toll-free number was given for the community members to answer that. So here you see at the bottom a Gram Panchayat president in doing a monitoring activity of his PHC. So based on the responses, we did field validation, went with the PHC personnel and analyzed the responses that the community had given, and went back again to the community to collect some feedback on what they felt about this kind of mechanism, and automatic scorecards were generated and those scorecards were disseminated. So it also involves a lot of IT infrastructure in terms of the scores get automatically converted into ranking. So the dissemination was pretty fast. So the major project outcomes were we have now a base. So it was not that we have a shortage of doctors, but also to present their own local problems. So the community also realized that a lot of things don't really rest with the doctors, and then the role of the community also tried to get their own roles and responsibilities. So in terms to quickly discuss the results, community is actually interested more to adopt this to panchayats and schools, so which is a welcome sign. Community feels empowered that somebody calls them and asks them, can you answer this question, and then says thank you, because none of that has happened. Technology is good, but a lot of that has to be streamlined based on local context, and people are apprehensive that somebody is monitoring them, which gets reported directly to higher officials, which may be a good sign but may be a bad thing as well.
Sham,
yeah.
I think that you should
I'll just stop.